All right. Hello, everyone. I'm Earl Sarow, and as Claire said, over the past few months, we've been using Geographic Information Systems, or GIS, technology to map the ALS registry to show how mapping can help us understand access to care, identify common lived locations, and locate the communities that are underreported in the National Registry. So first, a quick introduction about Pat Dolan. Pat has been a GIS professional for over 33 years. In 2016, he was diagnosed with ALS. After his diagnosis, he wanted to use his GIS skills to help battle ALS. Though he no longer can move, eat, speak, or breathe on his own, he continues his work as a GIS professional. Over the past 7 years, Pat has created hundreds of maps to support legislation, research, and clinical care. This is thanks to his eye-gazing device and the support of Esri and Team Gleason. In 2022, with the help of his former colleagues at Esri, Pat released the ALS Geospatial Hub, which brings information together by geography to discover patterns and relationships to improve care, accelerate research, and advocate for the ALS community. We invite you to join and explore the Hub and the information it provides. We'll give a link to the Hub during the question and answer session after this presentation. So I'm Earl Sarow, and I recently retired after 35 years with Esri, where I had the good fortune to work with Pat. Together, our claim to fame was working on the Godzilla movie, explaining to the director and writers how we would have used GIS to predict Godzilla's movements. Shortly after his diagnosis, Pat asked me if I could help him analyze the place history of ALS patients. Our goal was to map the places registrants had lived and then identify the environmental and demographic characteristics of those locations. We did this work in partnership with Danielle Boyce and Clare Durrett. We are excited to show the results of our work. Before we begin, I want to take a moment to acknowledge the work done by all the ALS advocates who provided advice to the CDC on how the registry can best serve the community. Sadly, we recently lost two of those advocates, giants in the ALS community, Sandy Morris and Becky Morey. So we're dedicating this presentation to Sandy and Becky. They're a reminder that we all need to work with a sense of urgency because this disease takes no breaks and it continues to take lives at an alarming rate. So we undertook a spatial analysis of the place history data in the registry to see what information we could extract from it. Our goal with this analysis was not to offer any groundbreaking insights into ALS, but rather to raise awareness of how GIS could contribute to improving and understanding the information in the registry. We hope that by doing this, we'll inspire some really smart and creative people to look at the registry in a different way that could lead to new insights and ideas for research. Here's a sample of the data we got from the registry. This information came from people who self-enrolled in the registry between 2016 and 2021. It doesn't include people who were found through other means, like extracting data from government or insurance databases. We received one row of data for each location reported by each registrant. This place history information included the city, state, and country where the registrant had lived, as well as a few basic bits of information about those places. We geocoded the records to get latitude and longitude coordinates for the cities listed in the place history. We successfully located just over 23,000 place history records from a total of just over 4,000 registrants. And this map shows those locations across the world. The first type of analysis we did was to look at the geographic distribution of the reported residence locations. Using just the data that we received in the extract, we mapped those locations and then we broke them out into different categories to get a better picture of where people had lived and when. We extracted the first reported location for each of the registrants, working on the assumption that each registrant's first reported location is the place where they were born. Again, these are located all across the globe, but not surprisingly, most were within the United States. Knowing the years that each person moved to and from each location, and the year they were formally diagnosed, we could start to divide the place histories into pre-diagnosis, at diagnosis, and post-diagnosis groups. The green dots on this map are the places where people lived in the years up to and including the year in which they were diagnosed. This information could be useful to researchers looking at potential exposure to environmental factors that could be contributing to ALS. And these are the locations where people were living during the year in which they were diagnosed. Looking for spatial patterns within these points could help direct efforts at outreach to newly diagnosed patients. And these are the places where registrants reported living during or after the year in which they were diagnosed. This information could be used to help determine whether ALS clinics are located in the places they're needed most, or if there are areas that are being underserved by the current set of clinics. It could also shed light on whether people have moved in order to be closer to an ALS clinic. GIS can help us better understand where care is needed rather than us making assumptions. Here, we've calculated the drive times from registrants' current locations to ALS clinics nationwide. The average drive time to a clinic is 51 minutes. But not everyone lives near a clinic. This analysis shows that 16% of registrants, the blue dots on this map, have to travel 90 minutes or more to a clinic. We also looked at access to clinical trials. We calculated the drive times to Healy platform trial sites. The average drive time to one of these clinical trial locations is 83 minutes. And next, we calculated the number of years that each person lived at each location. On this map, the size of the circle is proportional to the number of years that each person lived at each location. This information can be summarized by geographic area to determine the number of person years that were spent living in various areas. That could be useful for a study of exposure to a specific environmental factor, for example. We also mapped the location of each person lived at the time of diagnosis, symbolized here according to the year in which the person was formally diagnosed. So we were looking to see if there were any strong spatial patterns that could raise questions about what may have occurred in a specific area that would have caused a spike in diagnoses. We didn't see any strong patterns in the year diagnosed. And that's likely because the vast majority of diagnoses occurred in the first few years after the establishment of the registry. And finally, we mapped those locations looking for patterns in the age at diagnosis. Any strong spatial patterns here, such as an area with an unusually high number of diagnoses at a fairly young age, could raise questions about what kind of environmental factors might be at play in that area that would cause an earlier onset of ALS. This is a chart of the number of people diagnosed at each age from 20 to 90 years old. Previous reporting on the registry has indicated that ALS is most commonly diagnosed during a person's late 50s and through their 60s, and this chart supports that finding. With GIS, we can take another step in the analysis and start to look at relationships within the place histories of the registrants. We can use geostatistical methods to detect spatial patterns in the data that are not evident from just looking at a map of points. For this part of the analysis, we looked at just the pre-diagnosis locations of the registrants. We limited that analysis to the lower 48 states to eliminate the distorting effects of long distances across the Pacific from Hawaii and from Alaska through Canada. One type of analysis we can do is identify places where registrant locations tend to be lumped together. This map shows the pre-diagnosis locations for part of the eastern United States. Each dot is closer to other dots of the same color than to any dot of any other color. This type of analysis could help researchers identify geographic areas that might be of interest for detailed studies of environmental factors. We can go one step further in the analysis and look for cases where multiple people have lived at the same location for some period of time. Each circle on this map represents a city where one or more registrants have lived, and the size of the circle is proportional to the number of people who reported living there. Another way to represent spatial patterns is with density maps, like this one. In the red areas, there are more reported residence locations per square mile than in the green areas. This map helps us see the overall national pattern of the place histories. And finally, we can perform a hotspot analysis, a spatial analysis methodology that finds statistically significant patterns in the distribution of a data set. On this map, the red areas are hotspots, areas where the density of reported residents is greater than average, and that difference is statistically significant. The blue areas are cold spots, areas where the density is lower than average, and that difference is also statistically significant. One of the great strengths of GIS is its ability to link data sets together based on shared locations. If we know where the observations from two different data sets occurred, such as place histories and county boundaries with demographic information, we can use geography to join those data sets together for further analysis. And this is a simple example showing the locations where registrants have lived and locations of coal-burning power plants in the contiguous United States. This kind of information could be combined with information about power plant emissions, prevailing winds, and health information from the registry to look for relationships between them. The EPA collects and makes available many data sets dealing with environmental information. This map, made from EPA data, shows places where toxic chemicals have been released into the environment. We can map these data sets and use GIS tools to identify people who have lived in close proximity to any of these sites. And this is another EPA data set showing locations of industries that generate environmentally hazardous waste products that are regulated by the EPA. Again, if we know the precise locations where people have lived, we could map them and analyze their proximity to these sites. We also found an EPA data set that lists the amounts of various pesticides used by county over approximately 17 years. This map shows the average amounts of a specific fungicide used per square mile per year in each county. People living in the dark blue areas would potentially have a greater exposure to this chemical than people living in the lighter blue areas. And on this map, we've aggregated the number of person years lived at each location and multiplied that by the fungicide usage rates on the previous map in order to get a picture of the total potential aggregate exposure of registrants to this chemical. Next, we looked at relationships between the current last reported locations of registrants and a number of demographic data sets to see if there are any geographic patterns that stand out, such as areas that are over or underrepresented. For this part of the analysis, we used the most recent location of each registrant. Some registrants identified their current location in the survey, but for those who didn't, we used their last reported location. To link the registrant locations to demographic data, we overlaid them with the boundaries of public use microdata areas, or PUMAs, defined by the US Census Bureau. Then we summed up the number of registrants within each PUMA. We use PUMAs because they're relatively equal in population, as opposed to counties or states whose populations vary greatly. That avoids problems like small differences in the number of registrants causing huge differences in registration rates in areas with very small populations. This chart shows the results of that overlay, with the bars representing the number of PUMAs that had the specified number of registrants living in them. About 950 PUMAs had no registrants, and one PUMA had as many as 45. We calculated the number of registrants per 100,000 persons and then mapped the results. Red areas have a higher rate of registration than the national average, and blue areas have a lower rate than average. The map shows that the rate of registration is higher in the upper Midwest and parts of the Northeast and lower in the South and Southwest. This pattern is consistent with what other studies have found. Veterans are several times more likely to be diagnosed with ALS than the general population. So for our next analysis, we wanted to see if there's a pattern to the rate of registration relative to the percent of veterans in our analysis areas. We calculated the number of registrations per 10,000 veterans and mapped those results here. Red areas show a higher rate of registrations relative to the number of veterans than the national average, and blue areas show a lower rate. This time, the upper Midwest stands out a little more strongly than the rest of the nation, and some pockets of high registration in other parts of the country. ALS tends to strike people in their late 50s and into their 60s, so we looked at registration rates relative to the population aged 55 and over. We calculated the number of registrants per 10,000 persons aged 55 and over and mapped the results that were above and below the national average. Again, the upper Midwest shows higher registration rates than most of the rest of the country, but there are more pockets of high registrations, especially in the eastern half of the country. These patterns could be caused by several factors, like differences in the effectiveness of education and enrollment efforts in different areas, or regional differences in willingness among the population to provide personal information to the CDC. Or they could be reflective of patterns in the actual rate of occurrence of ALS within the population. The registration patterns we see are, in fact, similar to the regional patterns in deaths from motor neuron disease. One way to understand the characteristics of who is or is not joining the registry is to look at demographic profiles of the areas where we have high or low numbers of registrants. Tapestry is a method of classifying geographic areas according to the number of demographic characteristics, such as race, ethnicity, average age, income, wealth, and buying habits. This map shows the predominant Tapestry classification by zip code for the Chicago area. We overlaid this map onto registrant locations to identify which Tapestry segment each registrant lives in. Then we summed up the number of registrants that lived in each Tapestry category. This chart shows the top 10 Tapestry segments based on the number of registrants that lived in each area. And we can look at the characteristics of each segment to find out more about the areas where people are registering. One of the top 10 Tapestry segments we found is this group called Comfortable Empty Nesters. And this report describes that group in detail, their age, racial characteristics, income, spending, and occupations. Looking at this kind of information in detail for areas with high or low registration rates might provide insights into the demographics of who's joining the registry and who isn't. One area of great interest is identifying communities that are underrepresented in the registry. We know that minority communities are underrepresented, and we can use GIS to learn more about that. For this part of the analysis, we separated areas that have at least one registrant from areas that have no registrants, as shown on this map. Then we compared those areas to see if certain population groups are more prevalent in the areas where no one has registered. That could help us find out where those underrepresented groups are. First, we looked at the Black population. This map shows the percent of the population in each area that's Black. And these charts compare the percentage Black population in the areas that have registrants to those in the areas that don't have registrants. Areas without registrants have more Black registrants, more Black residents than areas that have registrants. So this confirms that the Black population is underrepresented. GIS could help us identify areas to focus efforts to enroll more Black participants. We did a similar analysis to look at under-enrollment of the Hispanic population. So this map shows the percent of the population that's Hispanic. And these charts show that the areas without registrants have a higher percentage of Hispanic persons than areas that have registrants. So it appears that the Hispanic population is also underrepresented in the registry. And again, we could use GIS to find areas to focus efforts to enroll more people of Hispanic heritage. Another group that might be underrepresented in this registry is those without health insurance. This map shows the percentage of people living without health insurance in each area. Looking at these two charts, there's only a slight difference in the percent of uninsured people between the areas with registrants and the areas without registrants. There might be a slight underrepresentation of people without insurance, but we can't say that for certain with the data that we have. There may be any number of reasons that people don't join the registry. So here we use geographic data to try to evaluate whether some of those potential reasons hold true. We thought one reason that people don't join the registry could be because they don't live near a specialty clinic. They might be seeing a neurologist or a general practitioner who either isn't aware of the registry or doesn't encourage their patients to join it. One test of this theory would be if the rate of registration drops off in areas where clinics are less accessible. So for this analysis, we calculated the fastest route to drive to the nearest specialty clinic from each PUMA. And here we've mapped the travel times required to get to those clinics. For the contiguous 48 states, those times ranged up to 7 hours. Now I need to mention that because of their isolation, Alaska and Hawaii were outliers with no clinics within a practical driving time, so we removed them from the rest of this analysis. This scatter plot shows the relationship between the rate of registrations and the travel time to the nearest clinic. Contrary to what we thought might be the case, there doesn't appear to be any relationship between accessibility to a specialty clinic and the rate of registration. Next, we thought that a lack of access to the internet might discourage some people from registering, since the survey is online. This map shows the percentage of households in each PUMA that don't have access to the internet. And this scatter plot shows the relationship between households without internet access and the registration rate. Again, there doesn't appear to be any correlation between them, so we can't blame the lack of internet access for low registration rates. And finally, we thought there might be a language barrier and that non-English speakers might be less likely to join the registry. So this is a map of the percent of residents that don't speak English. And again, we found no correlation between the percent of people who don't speak English and the registration rates. Researchers have identified other reasons that people give for not joining the registry. There's no mandate to register. They may not be aware of the registry. They may not be encouraged to register. They may not see the value of the registry, and they may be reluctant to share their personal information. One challenge for future research would be to use GIS to identify or evaluate these and other reasons for not registering. Another challenge is the current state of the registry data. The self-enrolled registry data has limitations that prevent us from using it to make accurate assessments of the ALS community. The first limitation is the low registration numbers. Stephen Finger points out that the registry represents about 5% of the patients diagnosed during the time period it covers. We need a complete head count to make accurate predictions on the prevalence of ALS. Second is address information. The registry only captures locations to the city level. This severely limits the value of the registry because it makes it impossible to accurately analyze local patterns of patients or their relationships to localized environmental factors. Third is the underrepresentation of minority populations. Our analysis verifies that minority communities are underreported, which impacts our understanding of ALS in those communities. Therefore, we must not assume that the results we got apply to the ALS community as a whole. And although there are several challenges in getting the entire ALS community to join the registry and collecting the level of detail needed for accurate analysis, we can see the value of this effort. Using GIS tools would allow us to see patterns and relationships between the ALS community and relationships to information and other data sources. Understanding those patterns and relationships can help accelerate research, improve access to care, and inform policy decisions needed for the ALS community. To maximize the value of the registry, we need the following. We need timely reporting of the registry data so that research and policy can be carried out quickly and with current information. We need people to see the data in action so they can see the value of registering. We need an increase in registration rates, especially for minority populations. And we need to capture the level of location detail needed for precise and accurate analysis. And finally, we need a place for researchers to share their analysis so we can build on each other's work. Now we'd like to open up the discussion for questions. But first, please take note of the contact information on the screen and the URLs to some of the resources that Pat has created. At the ALS Geospatial Hub, you'll find maps, applications, articles, presentations, and other resources. And if you're a person living with ALS or a caregiver that attends an ALS clinic, we invite you to take the ALS Clinic Survey to share your experiences at clinic. We currently have surveys for 65% of the ALS clinics in the United States. You can see all the survey results on the ALS Clinic Advisor dashboard. So at this point, we'd like to open up for questions.